Hello. Today we will cover the objectives for week 2. This presentation is in 2 parts, part A and part B. This is part B. Chapter 13, poisoning. So the emergency treatment of poisoning, this is in a table in your text. This is as follows. So the first thing that you're going to do is obviously assess the victim. We want to initiate CPR support if necessary, assess mental status and reevaluate routinely, take vital signs and then also reevaluate routinely, evaluate for possibility of concomitant trauma or illness, treat prior to initiation of gastric decontamination. You want to terminate the exposure. So empty the mouth of pills, plant parts, or anything else that might be toxic. Flush any body part, including the eyes, exposed to a toxin with large volumes of warm water or saline for 15 to 20 minutes. Remove contaminated clothes, including socks and shoes and jewelry. Ensure protection of rescuers and healthcare workers from exposure. Bring victim of an inhalation poisoning into fresh air. Third, we want to identify the poison. Question the victim and witnesses. Observe the circumstances surrounding the poisoning, like the location and the activity prior to ingestion. Look for environmental cues like an empty container. Did something spill next to them? Is there something on their breath? And then save all evidence. So a container, if they vomited, if they voided. Be alert to signs and symptoms of a potential poisoning in the absence of other evidence, including ocular or dermal exposure. Call the Poison Control Center or other competent emergency facilities for immediate advice regarding treatment. Next, we want to avoid or prevent a poison absorption. Place a child in a side-lying, sitting, or kneeling position with the head below the chest to prevent aspiration. Administer activated charcoal with a cathartic if necessary. We don't do this as much anymore. Note the usual dose is 1 gram per kilogram. Because it does resemble black mud, you want to give it in a covered, opaque, on a clear cup with a straw to decrease spilling. You might mix it in like chocolate milk, some fruit syrup, or cola drinks. If one exists, you would want to administer an antidote. And if a toxin was ingested within 1 hour, they may also perform a gastric lavage. And although this is not in your textbook, you do want to support the child and the family psychologically because this is an emergency and a very stressful time. So let's talk about specifically some categories of poisoning. But prior to that, please be aware that many houseplants are poisonous, so you want to keep them out of reach of children. So first, we're going to talk about corrosives. These are strong acids or alkalis. Example of these would be drain, toilet, dishwasher detergent, mildew remover, batteries, or bleach. Clinical manifestations include severe burning pain in the mouth, throat, or stomach. Then you're going to notice that the mucous membranes are sort of white and swollen, and you could also see edema of the lips and tongue. They may have violent vomiting, but we absolutely do not induce vomiting. They may have drooling and inability to clear secretions, signs of shock, anxiety, and agitation. As I mentioned, inducing emesis is contraindicated because the vomiting will re-damage the mucosa. Call poison control. Dilute the corrosive with a teeny little bit of water and milk, usually no more than 120 milliliters. And this is if there is no help quickly available. Don't neutralize because it can cause more injury. Definitely provide a patent airway and don't allow oral intake other than that little bit of water or milk, and they will give analgesics. Hydrocarbons. Examples of these include gasoline, lighter fluid, paint thinner, turpentine, kerosene or lamp oil, or mineral seal oil. This is found in furniture polish. Here, the clinical manifestations include gagging, choking, and coughing, nausea, vomiting, weakness, lethargy, and then respiratory symptoms of pulmonary involvement. So this, you're going to see this more if they aspirated. You would see tachypnea, cyanosis, retractions, and grunting. The immediate danger is aspiration. Even small amounts can actually cause bronchitis and or chemical pneumonia. Treatment, so it is controversial. Know that introducing emesis again is generally contraindicated. Gastric decontamination is questionable. If it is to be done, the child needs to have a cuffed ET tube in place because they want to prevent any of the chemical getting into the lungs. Generally, they provide supportive treatment. If they have a chemical pneumonia, they'll be in high humidity. They'll be given oxygen, hydration, IV antibiotics. If it is on their skin and clothing, please remove the clothes and wash their skin. Acetaminophen. This toxicity occurs in 4 stages. Initial period is 0 to 24 hours after ingestion, and they would experience nausea, vomiting, sweating, and pallor. The latent period is 24 to 72 hours, and the patient looks a little bit better. The hepatic involvement is usually 72 to 96 hours later, and here they're going to experience pain in the right upper quadrant, jaundice, confusion, stupor, coagulation abnormalities, renal failure, and pancreatitis. Stage 4, more than 5 days. Here, either there is a resolution of hepatotoxicity or they can progress to multiple organ failure. This can be fatal. Note that this is the most common drug poisoning in children. Typically, a toxic dose is 150 milligrams per kilogram in children. It's very important for parents to read drug labels. This does have an antidote. It's called N-acetylcysteine, abbreviated as NAC, also known as concentrated mucomyst. This is usually given orally, but it can be diluted in fruit juice or soda. And you would do that because it smells really, really bad. It smells like rotten eggs. If they throw up, they can be given an antiemetic. Given as a loading dose, typically NAC is usually 17 maintenance doses, and then they can be in different dosages. So you would give a loading dose, and then the following dosages will be different. Aspirin, so also abbreviated ASA. Here, the clinical manifestations. So these are the acute poisoning. So your early signs and symptoms would be nausea, hyperventilation, vomiting, and tinnitus, which is the ringing of the ear. Later symptoms of acute poisoning include hyperactivity, fever, confusion, seizures, renal failure, and respiratory failure. Chronic poisoning, they have the same signs and symptoms listed as above, but they have a little bit more subtle onset and they're a little bit more non-specific. Often they can be mistaken for a viral illness, but also for chronic poisoning, you will see bleeding tendencies. Treatment, hospitalization is necessary for severe toxicity. Activated charcoal is given as soon as possible unless it's contraindicated by altered mental status. If bowel sounds are present, it may be repeated every 4 hours until the charcoal appears in the stool. Lavage will not remove concentrations of aspirin. Sodium bicarbonate transfusions are used to correct metabolic acidosis, and urinary alkalinization may be effective in enhancing elimination. Hypokalemia may interfere with achieving urinary alkalinization. Be aware of the risks of fluid overload and pulmonary edema. Use external cooling for hyperpyrexia. Administer anticonvulsants if seizures are present. Provide oxygen and ventilation for respiratory depression. Administer vitamin K for bleeding. And in severe cases, hemodialysis, not peritoneal dialysis, is used. Next, we're going to talk about iron toxicity. Here, this is a mineral supplement or a vitamin containing iron. The clinical manifestations occurs in 5 stages. So initially, within 6 hours after ingestion, if the child does not develop gastrointestinal symptoms, typically within 6 hours, toxicity is unlikely. These would include vomiting, hematemesis, diarrhea, hematochezia, gastric pain, severe toxicity. They may have tachypnea, tachycardia, hypotension, and coma. Latency is up to 24 hours and the patient improves. Systemic toxicity usually occurs anywhere from 12 to 24 hours after ingestion, and you will see here things like metabolic acidosis, fever, hyperglycemia, bleeding shock, and death actually can occur. Hepatic injury, this is 2 to 4 days after ingestion. Jaundice, liver failure, hypoglycemia, and coma. The fifth phase would be pyloric stenosis or duodenal obstruction. Although it rarely occurs, it can occur after 2 to 5 weeks of ingestion. Treatment, what are we going to do? Hospitalization is required when more than mild gastroenteritis is present. Use whole bowel irrigation if radio-opaque tablets are visible on abdominal x-ray. You may need to be given via the nasogastric tube. Emesis empties the stomach more effectively than lavage. Activated charcoal does not absorb iron. Chelation therapy with deferoxamine should be used in severe intoxication. Know that this is typically given IV, and it may turn the urine red or orange. So let them know that so they won't be scared. If IV deferoxamine is given too rapidly, the patient can develop hypotension, facial flushing, rash, urticaria, which is a fancy way of saying itching, tachycardia, and shock may occur. You want to stop the infusion, maintain the IV line with normal saline, and notify the practitioner immediately if this occurs. Lead poisoning is actually in a separate section in this chapter. I'm not exactly sure why they put it separately. So lead poisoning is a heavy metal. It is poorly absorbed by the body and slowly excreted. Lead replaces calcium in the bones and increases the permeability of central nervous system membranes. Most common sources of lead are lead paint. And the good thing is that lead paint was banned in 1978 for home use. Lead gasoline was also banned in the United States. So we're trying to prevent this. Other things that can contain lead would be like sanding lead paint, soil, dust, water from lead pipes, using lead pans, poorly fired ceramic pots, and then certain traditional remedies. Azarcon is one traditional remedy that does contain lead and children should not be given. Diagnosis, lead levels 5 micrograms per deciliter on 2 consecutive blood draws. Lead levels should be checked at 1 and 2 years of age and any child between 3 to 5 years of age who has not been checked. So signs and symptoms. There's quite a variety of signs and symptoms, things like anemia, kidney damage, which can result in glycosuria, proteinuria, ketonuria, a decrease in vitamin D and impaired calcium function. Some effects on the nervous system include at low dose exposure, distractibility, impulsivity, hyperactivity, hearing impairment, mild intellectual deficits. High dose exposure can lead to lead encephalopathy, cognitive impairment, paralysis, blindness, seizures, coma, death, a lead line, which is a blue-black line on gum tissue, vomiting, constipation, weight loss, abdominal cramping, fatigue, lethargy, bone pain, and paresthesia. So what is the treatment? Levels between 5 and 44 micrograms per deciliter, they're going to monitor, educate, and do an environmental investigation. Typically, chelation treatment occurs over 45 micrograms per deciliter within 48 hours to provide coordination of care and clinical management. They will provide treatment and environmental investigation and lead hazard control. The child cannot stay in the environment if resolution is to occur. The child will receive medication that binds with the lead and increases the rate of excretion from the body. Examples of this would be calcium disodium edetate. This is given IM or IV. Dimercaprol, which is given IM. It can also be called BAL. And then DMSA, also called Succinir. For level 70 micrograms per deciliter, they need to have immediate coordination of care and clinical management, treatment, environmental investigation, and lead hazard control. The child cannot stay in the environment if resolution to occur, and the child will again receive medication that binds with the lead and increases the rate of the excretion from the body. Calcium disodium edetate and Succinir are the most consistently used agents. Succinir can be given orally, and they can swallow the capsule whole, or it can be sprinkled on food. BAL may be given with the calcium disodium edetate for levels of 70 micrograms per deciliter or more. You don't want to give BAL if the child has G6PD deficiency, a peanut allergy, or in conjunction with iron. Some side effects of the calcium disodium edetate is nephrotoxicity, nausea, vomiting, elevated liver enzymes, paresthesia. As a nurse, when we're giving this, especially if we're giving it for IM, you want to put the ELAC cream on for 1 hour. This is a deep IM injection. And then if you're giving the BAL, you're going to actually leave the ELAC cream on for 2.5 hours. It's not uncommon to have the BAL and the calcium disodium edetate used together. It is very important to monitor strict intake and output. We want them to have adequate urine output because remember, this does cause urine toxicity, nephrotoxicity. Teach parents to feed the child high iron and calcium diet because lead can actually interfere with calcium and vitamin D metabolism. It also can interfere with the central nervous system, blood cells, and kidney function. So how can we reduce blood levels, blood lead levels? Here we want to make sure children don't have access to peeling paint or chewing surfaces that's painted with lead paint. So paying attention to their toys as well, homes that were built before 1978. You know, if kids, sometimes they will, you know, bite on things. So we don't want them biting on windowsills or the wells. It's very important for those homes built before 1978, and they have hard surface floors. You want to wet mop them at least once a week. Wipe other hard surfaces like the windowsills and baseboards. If there's loose paint chips in the area, you want to use a wet disposable cloth to pick them up. Don't vacuum hard surface or windowsills or wells because it's actually spread the lead dust. You want to use vacuum cleaners with an agitator to remove dust from the rugs rather than vacuum cleaners with suction only. If a rug is known to contain lead dust and cannot be washed, it really should be thrown out. Wash and dry children's hands and faces frequently, especially before eating. Wash toys and pacifiers frequently. Wipe your feet on mats before entering the home, especially if you work in occupations where lead is used. You want to remove your shoes when you are entering the home. That's actually a really good practice for germ control as well as lead control. If the soil around the home is likely to be contaminated with lead, such as are they by a major highway or was a house built before 1978, these are examples of homes that the soil might have lead in it. You want to make sure that the children don't really play in those areas. Also, if the soil is contaminated, you know, you want to keep them away from even the plant areas, other grassy areas around the home, okay? And what you can do to prevent them from playing in those areas is plant bushes so that way they can't play there. During remodeling of older homes, you want to follow correct procedures. Be certain children and pregnant women are not in the home day or night until the process is completed. After the de-leading decontamination procedure, you want to thoroughly clean the house using cleaning solutions to a damp mop and dust before anybody returns. In areas where lead content of water exceeds the drinking water standards, and particularly the faucet, if it's not been used for more than 6 hours, you want to flush the faucet. You want to flush the cold pipe waters by running the water until it becomes as cold as it will get. And this can be anywhere from 30 seconds to 2 minutes. The more time the water's been sitting in the pipes, the more lead it might contain. Only use cold water from consumption. So it's drinking, cooking, and especially when you're using the water for infant formula. Hot water dissolves lead more quickly than cold water, and this contains higher amounts of lead. So that's the reason you don't want to be drinking the warm water out of the faucet, especially if they have like lead pipes. It is acceptable to use first flush water for non-consumption uses like bathing, because you're not drinking the water. You should have the water tested by a competent laboratory. This action is especially important for apartment dwellers. Flushing may not be effective in high-rise buildings and in other buildings with lead soldered central piping. Don't store food in open cans, particularly if the cans are imported. Again, they might have lead in them. Do not use pottery or ceramic ware that was inadequately fired or is meant for decorative use for food storage or service. Don't store drinks or food in lead crystal. Again, there are some products, the state of California actually will label the products that have lead in them, so you shouldn't be using those for food. Avoid folk remedies or cosmetics that contain lead. You also want to avoid candy imported from Mexico, like the tamarind hard candy, because that can contain lead. Some imported toys and toy jewelry can also contain lead. There have been certain situations where McDonald's has had to do recalls because their toys, they found out that they had lead in them. So this is an example of why it might be a good idea to avoid imported toys. Make certain that the home exposure is not occurring from the parents' occupations or hobbies. Household members employed in occupations such as lead smelting should shower and change into clean clothing before leaving work. Construction and lead abatement workers may also bring home the lead contaminants in their clothing. Ensure that children eat regular meals because more lead is absorbed on an empty stomach. Ensure that children's diet contains sufficient amounts of iron and calcium and not excessive amounts of fat. And then you want to consider iron supplementation if the child does not regularly consume foods that are rich in iron. Next, we are going to talk about child maltreatment. It is just terrible that this is something we have to discuss, but it is something that we will see. And remember, as a nurse, you are a mandated reporter if you suspect child abuse. So what is it? Basically, it's any intentional act of physical abuse and neglect, emotional abuse and neglect, or sexual abuse. Infants and toddlers are the most common victims of physical abuse. 50% of reported neglect cases are 3 years old and under. 74.8% of child maltreatment was neglect. School age and adolescents are at higher risk for emotional abuse. So types of neglect. Physical neglect is really the deprivation of necessity. So it's a failure to provide the physical or educational needs. So they don't provide food, shelter, clothing, supervision, or health care. Emotional or psychological neglect. This is where the caretaker is emotionally unavailable. They are cold and or uncaring towards the child. They don't give the child the personal affection, nurturing, or attention that they need. Emotional or psychological abuse. This is the deliberate attempt to destroy or impair a child's self-esteem or competence by rejecting them, isolating them, terrorizing, ignoring, corrupting, verbally assaulting, and overpressuring the child. Physical abuse. This is the intentional infliction of physical injury, and there's a wide variety of things that we can see here. So punching, beating, biting, kicking, burning, shaking, or anything that physically harms the child. Abusive head trauma. This used to be called shaken baby syndrome. So know that some people still use that term. This is important to know because not all abuse has external signs. Shaking the baby can cause intracranial trauma without external signs of injury. Nurses should suspect this in infants younger than a year of age who have subdural or retinal hemorrhages in the absence of external signs of trauma. Additional signs are failure to thrive, seizures, coma, respiratory irregularities, apnea, vomiting, and this is seen with an altered level of consciousness that can go from being drowsy to lethargic. Never shake a baby to wake them up, burp them, or when they're angry. And even if you're just trying to be playful, don't toss an infant in an air. That's not a good thing. Their little heads can't really balance, and then they can be brain damaged. Munchausen syndrome by proxy. So this is a person, unfortunately, it's more often the mother, who induces or fabricates an illness in someone else. So it's the child. Most often it's by the mother, like I said, in children, to gain attention from medical staff or increase self-esteem. The warning signs are the child will experience unexplained, prolonged, recurrent, or extremely rare illnesses. There's discrepancies between the exam and the history. The illness is unresponsive to treatment. The signs and symptoms only occur in the presence of the parent. The parent tends to be very knowledgeable about illness, treatments, and procedures. The parent is very interested in interacting with the healthcare team. They are very attentive towards the child, so often they won't leave the hospital. They might even have family members with similar symptoms. And then you want to look at, is the child's condition consistent with the reported history? Do diagnostic evidence support the reported history? Has anyone other than the caregiver witnessed the symptoms? Is treatment being provided primarily because of the caregiver's demands? Sadly, these kids undergo unnecessary and often painful diagnostic tests and procedures and therapies. The resolution of the symptoms after separation from the perpetrator can confirm the diagnosis. So there are some factors that predispose a child to abuse. The factors are parent, child, and environmental characteristics. So first, let's look at the parental characteristics. Although physical punishments tend to occur in abusive parents, most are not abused as children. If a parent was severely abused as a child, though, they are more likely to injure a child. They have difficulty controlling aggressive impulses. They express violence freely. They are socially isolated typically. They have low self-esteem, less than adequate parent functioning, drug addiction, marriage problems, little knowledge of appropriate parenting skills, and often they can have an unrealistic expectation for the child's age. The child's characteristics. So abuse is never the child's fault, but they may unintentionally contribute to an abusive situation. So birth to 1 year are actually the highest risk of abuse. The child that has the difficult temperament can be at increased risk for abuse. If they are hyperactive, physically disabled, brain damaged, illegitimate, unwanted. Also, premature babies can be at increased risk because they don't have the bonding and or a difficult pregnancy. Environmental characteristics. Here, this includes chronic stress, so things like divorce, poverty, unemployment, poor housing, alcoholism, drug addiction, social isolation, and having few friends. But please remember, this can occur in all areas regardless of race and socioeconomic status. Families that use caregivers in daycare may be at risk if they are not well vetted. So it is very important for families to pay very close attention to the caregivers as well as their daycare. Sexual abuse. This is the employment, use, persuasion, or coercion to engage in or assist any other person to engage in sexually explicit conduct or any simulation of such conduct. So fondling, incest, rape, molestation, intercourse, sodomy, exhibitionism, exploitation through prostitution or production of pornography, oral genital sex, and pedophilia. Significant risk factors for children, for child abuse include parental unavailability, lack of emotional closeness and flexibility, social isolation, emotional deprivation, and communication difficulties. Unfortunately, most sexual abuse is committed by men and by persons known to the child, such as family members. So, what are we going to do as a nurse? So when we're talking with children who reveal abuse, you want to provide them a private time and place to talk. You cannot promise to not tell anybody because you are a mandated reporter. So you do not promise them that you won't say anything. That's not something that's allowed. Don't express shock or criticize the family. You want to use vocabulary to discuss body parts. Avoid using any leading statements that can distort their report. Reassure them that they have done the right thing by telling. Tell them that the abuse is not their fault and that they're not bad and they have done nothing to deserve this and they are not to blame. Determine their immediate need for safety and then let the child know what will happen once you do the report. So what are some warning signs? So obviously physical evidence of abuse and or neglect, including previous injuries, conflicting stories about the accident or injury from the parents or others. The cause of the injury is blamed on a sibling or other party. An injury is inconsistent with the history, such as a concussion and a broken arm from falling off a bed. The history is inconsistent with the child's developmental level, such as a 6-month-old turning on the hot water. A complaint other than the one associated with the signs of abuse. So they bring the child into the emergency room because they have a cold, but they've got second-degree burns on their arm. Inappropriate response of the caregiver, such as exaggerated or absent emotional response, refusal to sign for additional tests or agree to necessary treatment, excessive delay in seeking treatment, an absence of the parents for questioning. Inappropriate response of the child, such as little or no response to pain, a fear of being touched, excessive or lack of separation anxiety, and then they may also have indiscriminate friendliness to strangers. A child's report of physical or sexual abuse. Previous reports of abuse in the family, repeated visits to the emergency facilities with injuries, and really probably the most important criteria of which to base a decision to report suspected abuse would be that incompatibility between the history and the injury. Also, you want to take a look at, we've mentioned the shaken baby syndrome, the subdural and or retinal hemorrhages in a child without external signs of trauma can be an indication of that shaken baby syndromes. In your textbook on page 423, they go into some thorough physical manifestations and behaviors of neglect and abuse, and we'll cover some of those right now. I'm not going to read the whole table. So physical neglect, suggested physical findings would be things like growth failure, malnutrition, poor hygiene, suggestive behaviors. They may have a dull and inactive affect. They might be very passive and sleepy. They might be absent from school. They might be stealing. Things that you would see physically for emotional abuse and neglect. Again, you might see failure to thrive, eating disorders, enuresis or sleep disorders. The behaviors that you might see would be self-stimulatory behaviors such as biting, rocking, or sucking. During infancy, you might see the lack of a social smile and stranger anxiety. You might see unusual fearfulness. They might actually lag in emotional and intellectual development, especially language and suicide attempts. So physical abuse, here's really a wide range of suggested physical findings. So here you could see bruises and welts. They might be in various stages of healing, so they could be anywhere in the body. And please note if they have like a regular pattern. So does it look like a belt buckle, a hand, a wire hanger, or pinch marks, burns? So here you can see these on the soles or the palms, the backs, or the buttocks. Typically, if you see it like on the, like a hand was like pushed in water, that could be a glove injury. If the foot was submerged in water, that would be called a boot injury. Anytime you see something like that and there's no splashing, that is something that you would want to, pay attention to. Patterns are descriptive of objects used, like a cigarette burn. So that would be like a round shape. If someone was burnt with an iron, you can see the little marks in the shape of an iron. I already mentioned the absence of splash marks and the presence of symmetric burns. That could be those gloves and boots injuries. A stun gun. Here, it's usually the lesions are circular and fairly uniform, and they're about 5 centimeters apart, and the actual lesion is less than a half a centimeter. Fractures and dislocation. So again, this could be anywhere, but note that spiral fractures is something that you would definitely pay attention to. You want to pay attention to the story, because the spiral fracture could be the twisting of the arm or the leg and then it breaking. Also noting, do they have, if they do a skeletal survey, which is an x-ray of the whole body, do they have old fractures as well that have already healed? Lacerations and abrasions. Here, again, this can be any place on the body. And then you want to also look at bite marks or pulling out of the hair. And forensics can actually determine the size of a mouth from a bite mark. So they can determine, if it's an adult bite mark. Chemical. So here it's repeated unexplained poisonings, like a drug overdose, an unexplained illness like hypoglycemia, because remember we talked about that Munchausen syndrome by proxy. Maybe they were given insulin. So suggestive behaviors. Here they're wary of physical contact with adults. They have a fear of their parents or of going home. They might lie very still while surveying the environment. They might actually have a lack of reaction to frightening events. They might become very apprehensive when they hear other kids cry. They might be very overly friendly and affectionate to other people. And they might also even withdraw. So sexual abuse, physical findings. Here you can see that bleeding, bruising, laceration, or irritation of the genitalia, anus, mouth, or throat, torn, stained, or bloody underclothing, pain on urination, or pain and swelling and inching of the genital area, penile discharge, sexually transmitted diseases, non-specific vaginitis, problems walking or sitting, an unusual odor in the genital area, recurrent UTIs, presence of sperm, and pregnancy in a very young adolescent. So suggestive behaviors here, you might notice they might start doing like public masturbation. They may have age inappropriate sexual play, or they might be very promiscuous or engage in overly seductive behavior. They might be very withdrawn. They may have poor relationships with their peers. In incestuous relationships, there can be excessive anger at the mother for not protecting the daughter if it was a girl. They can have regressive behaviors. They may run away from home. They can have a decline in school performance, and they can actually even be suicidal, so they can try and kill themselves. So nursing care. Here you want to meet the child's physical and psychological needs first. Do not interrogate by asking too many questions. Be specific and factual with all documentation regarding physical condition and behavioral response towards others. Do not examine the child alone. When a child comes in, you want to have two people present. That prevents anyone from saying, that mark wasn't here when I brought my child here. Take photographs as allowed. Refer to social services so the family can get the counseling for abuse cessation, parenting classes, family therapy, and support groups. Teach the parents the child developmental principles, and you want to serve as a role model. Let the child know that they did nothing wrong. As a nurse, again, you must legally report child abuse if you suspect it. So notice I didn't say that you had concrete proof. A reasonable suspicion is enough. You do want to observe the child and the parents' interactions. Although it is probably one of the hardest things that you have to do as a nurse, you must be non-judgmental. So recording assessment data in suspected abuse, you want to record the history of the injury. So the date, the time, where did it happen? Really get a sequence of the events with recorded times. Was there somebody there? You know, who was taking care of the child at the time of the incident? The time lapse between the child was hurt and they went to the hospital. You want to interview the child when appropriate, including verbal quotations and information from drawings or other play activities. You want to interview the parent, witnesses, and any other significant persons and include verbal quotations. And then you want to, again, have that description of the parent-child interactions. You know, what are their verbal interactions like, their eye contact, touching, and the parental concern. And then who else is in the home, you know, the names, ages, and the condition of them, if you know. And then physical exam is really a location, size, shape, and color of bruises, the location, and you want to put this in the chart on a body. Usually they have a cartoon body shape, and you can mark the location of the injuries. And really, it's much better to have pictures. Other things that you want to take a peek at would be things like, you know, symmetry or asymmetry of injuries, pain, do they have past injuries? And then again, doing a developmental test on the child to see if they are having any issues there as well. What can we do to prevent, or if it unfortunately happens, how can we help families cope with a child who has been sexually abused? Again, it's truly unfortunate. Sexual assault of children is much more common than most people realize. It may be preventable if the child has good preparation. To provide protection and preparation, you really want to pay attention to who is around the child. Let them know that unwanted touch can come from somebody that is liked and trusted. Always back up a child's right to say no. Encourage communication by taking seriously what children say. Take a second look at signals of potential danger. Refuse to leave a child in the company of somebody you do not trust. You want to include information about sexual assault when teaching about safety. Provide specific definitions and examples of sexual assault. Remind children that even nice people sometimes do mean things. What do we mean by a nice person? It could be a teacher. It could be a coach. So by definition, those are nice people. And so that's why you need to let them know this. Urge a child to tell if anybody around them makes them be uncomfortable. Prepare children to deal with bribes and threats as well as possible physical force. So here's where you may have to role play with the child so they can get away and they won't be fall victim to bribes or threats. You really want to eliminate any kind of secrets between children and parents. You want to tell a child that there's nothing that they cannot tell you. Sexual abusers may pressure children into secrecy. And this is why it is so important to let a child know that they can tell you anything and they should tell you everything. You want to teach a child how to say no, ask for help, and control who touches them and how. You want to model self-protective and limit-setting behavior from children. Should it ever become necessary to help a child recover from a sexual assault, these are some things that you would want to do. Listen carefully to understand what the child is experiencing. Support the child for telling them. You want to praise them, let them know that you believe them, and that they are not to blame. You want to know resources and help to choose them. Provide opportunities to talk about the assault. Provide opportunities for the entire family to go through a recovery process, because this is something that the whole family has gone through. Sexual assault affects everybody. So to help deal with this social problem, you want to provide sympathetic care and support to those who have been victimized. Recognize that offenders do not change without intervention. Organize neighborhood programs to support each other's efforts to protect children. Encourage children to provide information about sexual assault as a problem of health and safety. We also need to teach stranger safety. So as parents, something that you want to do is you want to avoid putting your children in personalized clothing in public places, meaning that you don't want to put their names on their clothing. Okay, so you don't want their names on the backpacks, on the outside, on their shoes. It's fine to put their names and the phone number on the inside of the clothing in case they get lost, but you really don't want it on the outside of their clothing, because it's very easy for a stranger to walk up to a child, read the name on their clothing, and just say, "Hello, Pauline." And if I have Pauline on my name, I'm going to think that I know who they are, when the reality is they just read my name. Also, teach children to never go with strangers. Here, what you can do is set up a code word. And so if somebody was to approach a child, let's say a parent really did have somebody different go pick up the child from school, and the child can say, well, what is the code word? If the person doesn't know the code word, they can't go with them. Always teach children to tell their parents if somebody makes them uncomfortable in any way, to let their parents know. Always listen to a child's concern regarding someone else's behavior. Teach the child to do anything necessary to get away from a stranger. Often, children are taught don't hit. Well, we need to let them know don't hit unless. So there are a few exceptions to that rule, and this is one of those exceptions. This is where you're going to teach them to scream, fall to the floor, kick, bite, do whatever it is that they need to get away. Also, organizing community groups to support educational treatment and law enforcement programs to help address this issue. Lastly, what we're going to talk about today is vaccines. And please make sure that you go to the cdc.gov vaccine schedule. It is on the website. You do need to know the vaccine schedule. So you could be asked like a select all that apply type of question. I don't require you to know how to do the catch-up schedules. I just want you to know overall, when should children and infants be getting the vaccines that they should be getting? Know that parents must be given the proper current vaccine information statement prior to administration of the vaccine, and they need to sign a consent. The VIS statements, or the vaccine information statements, are dated, so please make sure that they have the most up-to-date one. There is something called a CARES, and this is a registry that lets people know that the child had the vaccine. So they are automatically put in unless the parent signs the waiver saying that they are opting out. So a killed virus vaccine, this contains a killed microorganism that can still cause a person to make antibodies. An example of this is IPV. A toxoid is a toxin which is heat or chemically treated to weaken its effect, but again, can still cause a person to make antibodies. Tetanus is an example of this. You've got live virus vaccine. So a microorganism is alive, but it's weakened. Examples of this would be like measles, chickenpox, the inhaled flu vaccine, and a rotavirus. So most often live virus vaccines are not given to people that are immunocompromised. We already talked about going over the vaccine schedule, so please go ahead and do that for the CDC website. Just already mentioned the live virus vaccines. Oh, by the way, there may be exceptions to this rule if the child is HIV positive and healthy. So that might be the exception to the rule. Know that varicella vaccine may be administered simultaneously with the measles, mumps, and rubella, but they need to be in different syringes and different injection sites. If they are not administered simultaneously, then when you give one of the vaccines, so let's say you give the varicella first, then you need to wait a month at least until you give the MMR. It's always best to keep children that are ill, especially if they're infectious, keep them at home. We don't want them spreading whatever is wrong with them to other people. So there are some contraindications to vaccines. So a general contraindication includes basically if a child has an anaphylactic reaction to a vaccine, then they will not get that one again. Obviously, that makes sense. So the Tdap or the DTaP, contraindications here is encephalopathy within 7 days of the DTaP dose. Precautions include a fever greater than 105 within 48 hours of having the DTaP, collapse or shock-like state within 48 hours of the vaccine, seizures within 3 days of getting the vaccine, persistent inconsolable crying lasted more than 3 hours. We don't use the oral poliovirus in the United States, and that's actually very recently is no longer used for the most part in the world. So that's actually a really good thing. And the reason it's a good thing is because the problem with the oral poliovirus vaccine is it can actually cause people when they've taken it to shed live wild poliovirus in their stool. And that potentially makes it so people can actually get polio. Polio is almost eradicated in the world. There's only a few more places that still have it. And I believe that's Pakistan and Afghanistan. So inactivated polio vaccine, so this is actually an injection. And this is what we give worldwide now. The contraindications, anaphylactic reaction to neomycin or streptomycin. It's given precaution in someone who's pregnant. MMR contraindication is pregnancy, immunodeficiency, obviously because that's a live virus vaccine, or if they have anaphylaxis after eating gelatin or neomycin. Some precautions to think about. If somebody was given immunoglobulin, so you do not want to give immunoglobulin and MMR at the same time. If it's unavoidable, you give them at different sites and then you revaccinate or you test for seroconversions in 3 months. So you want to see, did the MMR actually take? If you give the immunoglobulin, you want to wait really many, many months before you give the MMR. It really depends on the dose. If the MMR is given first, then ideally you don't give the immunoglobulin for at least 2 weeks. Precautions is thrombocytopenia. Hib vaccine, there's no contraindications. Hepatitis B vaccine, here the contraindication is anaphylactic reaction to common baker's yeast. Varicella, here the contraindication is, again, the immunocompromised individual, pregnancy, corticosteroid use. Usually they will wait many, many months if somebody is on corticosteroids to give varicella. And then anaphylaxis after eating gelatin. pneumococcal, usually if they have a moderate to severe illness with or without a fever. Influenza, here acute febrile illness, a history of Guillain-Barré. Please note that egg allergy is no longer a contraindication. There are certain ways that they would give the flu vaccine if they did have an egg allergy. But if somebody is concerned with that, an age-appropriate recombinant or cell-cultured product can actually be used for patients who refuse to receive an egg-based vaccine, or also the parents don't want their child to have it. So know that nurses are at the forefront in providing parents with appropriate information about childhood immunization benefits, contraindications, and side effects, and effects of non-vaccination on the child's health. Some suggestions for communicating with parents about the benefits of immunizations in childhood include the following. You want to provide accurate and user-friendly information on vaccines, the need for each one, the disease it prevents, and potential adverse effects. Realize that the parent is expressing concern for the child's health. Acknowledge the parent's concern in a genuine, empathetic manner. Tailor the discussion to the needs of the parent. Avoid judgment or threatening language. Be knowledgeable about the benefits of individual vaccines, the common adverse effects, and how to minimize those effects. Give the parent the vaccine information statement before vaccination and be prepared to answer any questions that may arise. Help the parent to make an informed decision regarding the administration of each vaccine. Be flexible and provide the parents with options regarding the administration of multiple vaccines, especially in infants who must receive multiple injections at 2, 4, and 6 months of age. So what that means is maybe we're going to allow the parents to space the vaccines at different visits to decrease the total number of injections at each visit. Make provisions for office visits for immunization purposes only. Ideally, they're not going to get a fee for this. And if we can do this, this is something that you may want to implement if the parent is concerned, provided that the child is healthy. Involve the parent in minimizing the potential effects of the vaccine, like giving them an appropriate dose of acetaminophen 45 minutes before administering the vaccine, if it's allowed. Apply ELAC cream or the 4% lidocaine to the injection site before administration. This helps to facilitate that atraumatic care. You want to follow up to check on the child to see if there's any kinds of reactions that's occurred in the past or the parent is especially anxious about. And then ultimately, you're going to respect the parent's wishes. So this actually concludes the presentation for week 2, part B. Thank you very much and have a good day. Bye-bye.